Good morning, Dr. Whitaker, and thank you so much for inviting me to be on this important panel. I'd like to start with Jasmine. Jasmine is, or should I say was, a resident of Illinois. And Jasmine didn't have a voice, and today she will have a voice. Allow me today, in this moment, to be Jasmine and her voice. Thank you, Dr. Jones, for this invitation. My name is Jasmine. I was an African-American woman in my 20s. Throughout the end of my pregnancy, I had frequent pain in my side and pain and numbness in my leg. And during my pregnancy, I visited the hospital department 8 times for various reasons, including pain. I delivered a beautiful, healthy baby boy, but experienced severe leg pain during the hospital stay. I was discharged from the hospital the day following my delivery, and I was instructed to return for an MRI if the pain persisted. I went to the emergency room twice the week following my delivery. The first time I presented to the hospital, I was admitted for pain management and discharged the next day with ice packs and pain medication. 3 days later, I represented. And this time, I had an examination which was limited by my pain. And all in my leg were not thoroughly examined for blood clots. I was discharged and told to follow up with my primary care doctor. Please note that I was screened for drugs multiple times, and repeatedly my screen was negative. By the way, no, I do not have a history of prior drug use. 1 week after my last visit to the emergency department, I collapsed in my home. I was taken to the hospital in cardiac arrest. I, Jasmine, died 18 days after the delivery of my beautiful baby from a blood clot that had traveled from my legs to my lungs, a pulmonary embolus. I, Jasmine, was denied the opportunity to be the mother that I had envisioned being to my beautiful baby. I, Jasmine, was denied the opportunity to contribute to my family and community in a meaningful way. I, Jasmine, was not allowed to be the matriarch that I envisioned for the next generation. Thank you, Dr. Jones and Dr. Whitaker, for allowing me to have a voice. I hope my voice is heard not only in this forum, but across this nation. My name is Jasmine. Dr. Whitaker, I wish I could say that Jasmine is the only case, but she's not. If we look at the maternal mortality rate in the United States, while nations, that rate is declining, in the United States of America, that rate continues to increase. And not only that, there's vast disparities in racial and ethnic backgrounds. This is in the United States of America. I think it's important that we realize that maternal morbidity and mortality is viewed internationally as an indicator of the health status of a nation, of a community, and of a state. And while maternal mortality is declining in other developed nations, maternal mortality in the United States of America, this beautiful, powerful country, is increasing. And not only is it increasing, but there are vast disparities when you look at racial and ethnic profiles. This is a public health emergency. It is a public health issue, and Jasmine, unfortunately, and her family have not been the only ones affected. Thank you, Dr. Whitaker.
Thank you, Dr. Jones, for kind of opening us up here and giving a voice to Jasmine, who died of a blood clot that traveled from her leg to her lungs. Dr. Jones, what you describe is, you didn't describe a trouble with access to actual care. And would it be safe to say that Jasmine received the majority of her prescribed prenatal care?
For Jasmine, access to care was not the challenge. For Jasmine, not being heard, not being listened to, unfortunately, not making an appropriate diagnosis, that resulted in her demise, unfortunately.
So we talk a lot about implicit bias in the system. You said she was reviewed for drugs several times, but never sent for that screening ultrasound, DVT kind of review. What is your thinking there about the implicit bias, and what is our opportunity as a profession to try to make a change here? Mm-hmm. So Dr. Jones, we don't hear you.
Implicit bias exists. It's not new. If there's any good news about this, Dr. Whitaker, is we're at least having the conversation. We have at least admitted that there's a problem with implicit prejudices or implicit bias. The question is it only implicit bias? Yes or no? What does one do with implicit bias? And does it only exist within certain communities? But let me state this, implicit bias does exist. Unfortunately, it's more common within certain communities. And until we decide that this is affecting health outcomes across our nation, maternal health, when you look at Latinx and African American women, our outcomes will continue to be unfavorable. In the nation, African American women are 2 to 3 times more likely to die from a pregnancy-related condition. Unfortunately, when you look at our state, African American women are 6.5 times more likely to die from a pregnancy-related condition. That's not just due to access or comorbidities. That, Dr. Whitaker, is due to implicit bias, structural racism, social determinants of health, health literacy, employment or unemployment, quality of education, food deserts, housing availability. So this is bigger than healthcare. And we all own this one. And therefore, we collectively have to come together. And when I use the word we, let me define we. We means the healthcare providers, the hospital, insurers, policymakers, government officials, the community, and patients and their family.
Thank you, Dr. Jones. I want you to put a pin in that and then put yourself on mute. We're going to go to Dr. Green for her opening remarks and comments. Dr. Green, you know, we convened together back in February, and you may touch on that, but we're going to do that after your comments if you don't. But can you kind of, you're the co-founder, CEO of Family Christian Health Center. It's in the South Suburbs. And, you know, you have some kind of firsthand experience with the ability to appropriately refer women who may need that next level of screening, ultrasound, or been identified with an issue. So I'm going to ask you to kind of start with your opening remarks, please. And
Sure.
then we can have a discussion.
You know, thank you so much for the opportunity. You know, when listen to Dr. Jones tell the story about Jasmine getting a voice, you know, and she talked about we. I say the same thing when we talk about the Constitution, we the people. Well, we on this call just heard a story, and so Jasmine does have a voice, right? Because it's up to us. We are the people that can fix this. So that way, when we take the information that we have today, it doesn't just stay here. And so one of the things I really want to stress is the ability for us to really own the situations that we see that are occurring, and then how do we collectively do that? So part of the challenge I realized when I really became aware of how bad the statistics were, I was like, oh my God, you got to be kidding me. I'm a physician, I work here every day. I'm a county trained physician, south side of Chicago. Our clinic is in the far southern suburb, I was in the southern suburbs and the far south side, but we service 59 zip codes. And that being said, I was appalled at the numbers. And we got together back in February and put a forum together, and it was called Breaking Silos and Taking Action. And it was an amazing opportunity that we had healthcare professionals and social service agencies throughout the city who were doing work, but we weren't talking to one another. And so this gave us an opportunity to talk, to share. How do we change things? How do we make it better? Because the people that we're talking about, Jasmine on this call could be somebody's sister, neighbor, friend, aunt, somebody. And so therefore, this opportunity allowed us to really begin to network. And how do we move the needle forward, right? We have the data, we see what's here. So how do we put changes in place that allow us to do that? Well, our next step was to take the information that we had learned and then move forward. And then COVID hit. And all COVID did was uncover the problem that already existed. For the south side of Chicago and far in the southern suburbs, if you look at the catchment area, there are about 300,000 women of reproductive age in the surrounding communities. Well, of the hospitals that women had access to care to, 3 of them had already closed their borders within a short period of time. And then post-COVID, due to economic safety reasons and things like that, those women found themselves having access to other institutions. Not only the women, but the providers themselves were trying to figure out, where do I send my patients? How do I navigate this? And we were having trouble before that, but now that COVID has existed, it was even more complicated. When we think about a woman that's on the south side of Chicago and she doesn't have access to necessarily a medical district where you have a catchment area of proximity hospitals that you can go to get testing to. You can be on the south side, and if I need to get you to a maternal fetal medicine physician, that can be a 2-hour ride to the hospital to get that test, right? And that's just one way. So we're not even talking about coming back. On top of that, imagine me trying to navigate that in the middle of COVID, and I have 1 or 2 other kids with me on public transportation. And so when we looked at some of the barriers and things that we were discussing, we put a Facebook Live together. And when we put the Facebook Live together, which was in May, it was amazing opportunity for 5 to 6 ObGYNs who are out doing this every day to come together to really talk about the structural and challenges that they had faced prior to COVID, but now with COVID, the other complications. The good news out of that conversation, though, is I remember getting a phone call back from Dr. Goyle and said, Dr. Green, we heard part of the conversation about blood pressure cuffs, and that one of the doctors was really having a challenge just getting a blood pressure reading, and how she was able to have a conversation, get access to someone with a blood pressure cuff, and that woman's life got saved by coming in early, right, for preeclampsia. He ended up talking to Teresa Eggleston and end up changing policy so that all women in the state of Illinois on Medicaid get a blood pressure cuff. And I was floored. We were back almost in tears, because for something as simple as that, if you're out trying to navigate and take care of a patient, that's huge information. That's huge data that you can have access to make your changes and be able to provide care. And you would say that a blood pressure cuff is, $40. But if you don't have that $40, if you don't have access to even getting to the store to get that $40 for you is like having $4,000.
So Dr. Green, I just want to stop you right there, because there's a couple of things you're kind of getting at here. One is during COVID, we started doing telehealth visits, and again, the jury's out on where telehealth is the most effective. But in this case, there were women who were assigned telehealth visits who may have been at risk for kind of developing preeclampsia. And we started seeing them over the phone, and it wasn't clear that that vital sign was being captured, right? So we leaned in, and we were able to connect with the state director of public health and a state director of Medicaid. And so you're right, we did make that an aware policy that went into place. But can you talk a little bit about the sort of failure of telehealth when we're trying to really monitor women at high risk for developing like a preeclamptic type picture, and why in COVID-19, for a number of reasons, that probably did not work?
Telehealth gives you a snapshot. When you're pregnant and there's complication, you don't need a snapshot, you need the whole story. And that whole story needs to be face-to-face. It needs to be an on contact where you can actually talk to the patient, but you can actually listen to them, that you can check their fetal height, that you can do an urine dip. So telehealth works great for low-risk women who you can get some initial prenatal care visits. But for a lot of our patients, what happens is there are other complications. And as Dr. Jones mentioned, those other social determinants of health impact things. These women were trying to do Zoom calls with their kids for school. They were trying to access all that was happening on the Black Lives Matters, and all these other complications and stress and social other barriers that impact that. We know that those outcomes or those impacts also have a huge huge impact on pregnancy. So because of that, these women still needed to be seen, but the barriers that we had prior to COVID only got exacerbated during COVID because now there are choices and limitations to them getting access to the care. And same thing with the doctors, trying to find places where they can go, who will take their insurance, how are they going to get there, how do I get the care coordination? These are all factors that we can lay down and they look good on paper. But you try picking up the phone and calling and navigating that and connecting that woman to do that, that's a different story. That is a very different story. And so I think lesson learned from this is that, yes, in instances, we absolutely need telehealth to be able to do it, to give that snapshot, that image that allows us to connect. Maybe you get a chance to connect with the dad in that scenario. Maybe you get a chance to see some of the other issues and conversations of family dynamics. But for women that have complications with diabetes, hypertension, thyroid, other issues, those women need access to care that is within proximity, that is within their reach, that helps partner with their primary care providers as well as with the specialists to make sure that they have an ecosystem for success. So then we're not listening to them 2 years from now or another year from now, and it's not a Jasmine, but it's somebody else's voice that we're listening to.
So Dr. Green, I'll never forget the day that we heard that. So you touched on another issue, which is really failing networks for referral for labor and delivery. I'll never forget the day we heard that St. Bernard was abruptly closing their labor and delivery. And then in short order, Advocate Trinity closed their labor and delivery. And a bunch of us African-American doctors from internal medicine, ObGYN, family medicine, we hopped on the phone because we were horrified. And you're closer to it because you're at Family Christian, you're referring women into some of these facilities. And I want to say, Dr. Green, that, you know, in retrospect, the New York Times somehow found Dr. Bradshaw, Joy Bradshaw, who's over at St. Bernard, who's an ObGYN there. It got more pub from the New York Times and other places than it actually did here about what the impact would be on the women who were seeking pregnancy care. So can you, just for the audience, kind of recount how you remember feeling and what you felt and what you sort of experienced when you heard St. Bernard, then Advocate Trinity were both closing L&D during the midst of COVID-19?
I personally was horrified because we know how far and how many barriers that our patients have and the outcomes. And so several of us got on the phone together to try to figure out, and I noticed some of the doctors were talking on Facebook. How can you go on Facebook to look for access to get your patients? That made no sense to me whatsoever. I said, there has got to be another mechanism of way of communication. I realized that we were all running at 50 speeds, but at the same time, it was our duty and obligation for these practitioners, providers, as well as the patients. And so that's when we really began to, how do we communicate this with one another? What was that network like? You have physicians who, yes, their information had been communicated, but physicians who worked at some of the institutions who still didn't know what some of that communication was. And so I think, can we do better and we can learn from this? Absolutely we can. And I think that when we do that, what happens is you open up the door when you really include some of the providers, because I think sometimes what happens is we have the network of administrators as we're working through, we will have the medical director, but sometimes the voice of the actual people that are boots on the ground doesn't necessarily make it up to the 5th floor, right? And so I think we have to do a better job of ensuring that the voices of the people that are out doing the work still have the ability to be heard in some of the decision making. And that's how you prevent the New York Times present an article out that locally here we didn't know about.
Well, I want to applaud, though, Dr. Green, like the network of physicians that came to the table, really. You know, Ingalls, chair of ObGYN, got on the phone with, you know, all of us, plus University of Chicago docs got on. And we basically, with bubble gum and tape and string, tried to just figure out what we could do, because the system itself was failing, right? The networks were experiencing massive failure of network. And I think what, you know, we can all agree on is that we'll never really know. We'll know in retrospect once we look at the data and we have the information on who delivered where and what their outcomes were, we'll never really know the impact on the physical health of that mom. And I doubt if we'll ever know the impact of the mental health disruptions that were caused. So, this is a great collective group on the phone. And I'm hoping that you and Dr. Jones can sort of make a few recommendations. We've told the Director of Public Health, and we can do the same for the Medicaid Director, that we want to put together a series of recommendations that we like to make. But before we do that, we're talking about hospital closures, and again, that's about networks, failing networks that are beyond our control in many cases. What did you all think about sort of the Mercy closure and the impact that it might have? Lisa, it's out of your service area, but do you have any thoughts there? And I'll let Dr. Jones go first. Dr. Jones, are you there? I know you. What are your thoughts there about the sort of network adequacy and proximity to services?
Well, when you use the word network adequacy, I think the word you really want to use is network inadequacy. Because as we close more and more hospitals throughout this city, it has to have both direct and indirect impact on the most vulnerable individuals in the city. So it's alarming to hear that in the midst of a pandemic, labor and delivery units are closing and hospitals are closing, but we have to come together and make maternal health and maternal health outcomes a priority. It has to be a priority. And until we do that, unfortunately, I think we'll continue to see inadequate health care within not only this state, but across this nation for vulnerable groups of individuals.
Thank you. Dr. Green?
I think that, I have to echo what Dr. Jones said. And we realize that hospitals have financial constraints, there are things with safety, because one of the hospitals did, Trinity opened back up because part of the conversation that they had was they didn't think they could do it in a safe environment. And that's understood at the time. But what's not understood is that the level of communication down that really reached the provider so they could provide care and be involved in that decision. It can't be the afterthought and the response. I think we're better than that. I think there has to be the ability to have communication with the people that are boots on the ground, that are doing the work, not necessarily reading a report about what they do, but actually having them at the table so that when the decisions and the communications are made, it is transparent, it is allowed to be able to take that information to ensure that there are safety measures, that there's other educational tools that need to be mended together before a final, wake up. Because what happened here was, it's not happening tomorrow. And so we've had to then find ways to then navigate through that system. And so I think that as we look at this, I totally agree. We have to make it a priority. And as we make it a priority, then we put the resources and we put the pen to paper with policies to ensure that we have an ecosystem that works for the South Side. I think, it goes back to, and I keep saying, we don't have what takes a 15, 20-minute transportation in the rest of the city can take 2 hours on the South Side of Chicago to get someplace. And that's a real issue for people. And so when you talk about access, it also has to be not just with insurance or the providers, but it has to be within a proximity that's reasonable enough that will allow patients to be able to get in at a sooner time and allow the providers that are working to know that when their patients are coming through the door, that they have not had all these extra barriers. We can't always fix everything, right? You're not going to fix poverty overnight. You're not going to fix, but the things that we can fix, we have to make that a priority to do.
So just to share with our group here convened is on Monday, the Illinois Senate convened the Public Health and the Human Services Committee. They had probably 15 speakers, and this came up several times. The maternal health desert, Southside is a case study if you will. There's certainly other areas in our state that are impacted, but the health of women overall, it does need to become a priority if we're procreating and providing the next generation, of life. That we are conscious and we're making conscious decisions. So I think honestly, perhaps a recommendation that a real work group, right? So we have to have solutions that are sustainable or viable. Maybe Mercy doesn't have as many beds. Maybe it's a smaller hospital, but it's still offering necessary services, right? Like, what are the solutions that are financially viable and make sense? And then number two, we have to ask the questions of where are we currently spending money? Because we are spending quite a bit of dollars in healthcare in Illinois. Like for the Medicaid budget, it's well over $20 billion. So where are these dollars going? That we also have to ask, because is there a structural financing issue that is causing this level of closure? Hospitals are shutting down services. In some cases, they may be open, but they don't offer, certain services, right? So we also have to be thoughtful about not just the doors open, but that the services that community needs is available. So I think, yes, go ahead, Dr. Green.
I think, and the other thing that we have to look at with all this modern technology, we have to look at a platform that really allows people to be able to communicate, the providers. It is very difficult and challenging for patients that are now just showing up at the hospital. That happened before COVID, but now when patients just show up and it's, their third trimester getting ready to deliver, and the stress that the providers have to endure now at 1 or 2 o'clock in the morning, trying to figure out when they had a last hemoglobin A1C, how much information did they have? Did they really make all their prenatal visits? It is a challenge to get on the phone and call these various entities that they can remember. Now, it's hard for people to remember, let alone during the day, but pregnant and at 1 o'clock in the morning in labor pain, they may not always have all of that information. And so we really need to look at a network that we can create with technology that would allow us to be able to exchange information. I think that would be able to give the providers the information that they need in a safe environment that would really allow them to take care of their patients while we're trying to figure this part of the ecosystem out. There has to be, and I agree with you, where we look at where our finances are structurally, and then how do we take the low-hanging fruit that we know that will give us the long-term sustainability and an ecosystem, but we have to start now.
May I add also, and I want to emphasize, because Dr. Green, I think you laid it out. I'd like to add, if we're able to send men and women to the moon, if we're able to do teleconferences across the Atlantic, if we make this a priority, we can do this also. And with COVID, in the midst of a pandemic, we have to do things differently. We have to ensure that everyone has access to telemedicine, and not just say telemedicine or telehealth is available, but do they have access to it? Do they have the ability to use a broadband system? Does their community have access to it? So we can't allow certain things to be available for certain populations, but not available for others. So we're basically shining a light on something that has been in existence for, I would probably say, centuries. But today's a new day, and we need to make it a priority. Maternal health is a priority.
Right. And it's not a priority for poor people, because let's remember, when you look at the structural implicit bias, you will find that your economic status or education doesn't necessarily protect you from this, right? But imagine now with the other struggles of issues that you have, it just complicates it even worse. And part of our discussion before, you can't say that in certain zip codes, if people were not going to have access in a certain period of time, that it wouldn't have been an emergency, as it should have been for our communities. And so I think now is an opportunity to really be able to navigate through and put a system in place that allows us to do better, because we can.